Okay. 2 minutes. Oh, okay. Just preempt. Just so it doesn't. It's that while we're talking.
The whole documentation. But I guess you guys. And same with internal. It hasn't gotten. That can
Like you are many.
Yes. A lot of body building ultimate and very. I mean, we have our own grand round theories that kind of think somebody would probably be. That's very, they're specific. And a lot of it's really, we've got hearing types. Parasite. A lot of I can look at my own.
Yeah.
Infections and that. You know.
That's
for sure. Yeah. Well, that. That's interesting. Right.
All right.
Yeah.
All right. It's 12:30, so we're going to go ahead and get started. Thank you for joining us today for the South Texas Regional Family Medicine Grand Rounds. Our educational partners are the South Central Area Health Education Center, and our department's mission statement is inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. All right. Today is February 5th. 2025, and today's attendance code is 10096244. And you can claim CME credit via text using the instructions on the screen. American Academy of Family Physicians members can use your AAFP login and claim credit for this activity online. This live activity, the South Texas Regional Family Medicine Grand Rounds, has been reviewed and is acceptable for up to 1 prescribed credit by the AAFP, and physicians should claim only the credit commensurate with their extent in their with the extent of their participation in the activity. Our Grand Rounds address the following nationally established physician core competencies: the Institute of Medicine core competencies, the ABMS ACGME competencies, and the AAMC competencies. And Dr. Shi will now introduce our speaker.
Closer to the microphone.
Well, it's my great pleasure to introduce Dr. Anthony Hartzler. So he is an associate professor at UT Health Division of Medicine with Division of Infectious Disease, Department of Medicine. So he attended medical school at Case Western Reserve University in Cleveland, Ohio, then completed his internal medicine residency and ID fellowship here at UT Health San Antonio. In 2009, he joined the faculty position here with UT Health, providing patient care as academic hospitalist and infectious disease attending. So in 2023, he was promoted to medical director of transplant and infectious diseases. He spends majority of his time as attending in the inpatient transplant ID consultant service. In addition, he's a medical director of UT Health Infectious Disease Clinic at the West Gateway Clinic location, where he provides care for patients with HIV and a variety of other infections, as well as heading the travel medicine clinic. So Dr. Hartzler most enjoys teaching in a clinical setting, but also gives a number of talks for medical students and leads ID board review programs for the fellows. So without further ado, let's hear about Dr. Hartzler on pneumonia updates. Thank you.
All right, yeah, thanks for the introduction. So how many people do we have online? Do we know? 9. Okay, so it's a fairly small group. I love to keep it interactive, and so if during the talk there are things that you feel like you want to raise your hand and shout stuff, questions, complaints, feel free, and we'll address them, in real time. And maybe you could help, if y'all could help with the online. I'm not sure that I'll see the comments or anything. So, okay.
Absolutely.
So yeah, in the spirit of keeping it interactive, let's start with a case that I'm going to need some help with. So a 60-year-old woman who's showing up with, she's got a history of hypertension, smoking, and homelessness. She has 3 days of productive cough, sore throat, rhinorrhea, fever, chills, and myalgias. Her friend has the same symptoms. Tmax is 104.3 Fahrenheit with pulse of 114, normal blood pressure and oxygen saturation. She's tachypnic with mild bronchi and right basilar rales. White blood cell count is normal. Respiratory viral PCR panel is negative, and chest X-ray is normal. So does this patient have pneumonia, and what are your next steps? And I'll accept, I don't have a audience response system, so shout out what you would do for this patient. And really, we're wondering, does this patient have pneumonia? Lung POCUS, so I love it, and that is definitely part of the talk. So additional imaging is great, and actually lung POCUS is not what I expected to be somebody's first choice, but it probably should be. Anything else we could do? What's that? Yeah, so sepsis work, exactly, for sure. So blood cultures and lactate and that sort of thing. Yeah, definitely. So in distinguishing whether the patient has pneumonia, would anybody do a procalcitonin? Okay, so one for procalcitonin, and then additional imaging. I love POCUS. Is there anything else you might do? I mean, we've got an abnormal exam, so I'm actually glad nobody went for the CT chest. Let's start with procalcitonin. So have y'all been using this in your inpatient services? I'm seeing some nods. So procalcitonin is released by macrophages, and it's specifically thought to be released in response to bacterial infection. Studies have supported its use, but for the most part, what they've done with these studies is take a population of people, and then you look at what are the outcomes if you use procalcitonin to guide the management. And it seemed to show no difference with using procalcitonin to do things like start or stop antibiotics versus just treating everybody. And the issues with this, obviously, these are small studies. And then in some cases, the studies would allow, if you were assigned to the procalcitonin group, they'd say, well, the clinician could override it. So if you're like, no, I really think the patient has pneumonia, even though their procalcitonin is negative, I'm going to give antibiotics. So lots of flaws with these studies. There was a fairly recent meta-analysis that actually looked at the question of, does procalcitonin, does the patient have bacterial infection or not? They were able to find 12 studies that had sufficient data. And in 8 of those, they had this cutoff of 0.5. One of the problems is, what do you use for a cutoff? So using a cutoff of 0.5, the sensitivity was 55% at identifying bacterial infection. So basically, if you had 100 patients with bacterial pneumonia, 55 of them would have a positive procalcitonin. So pretty poor. The specificity was 76%, which you could look at it looking at 24%. If you had 100 patients that didn't have pneumonia, 24 of them would have a positive procalcitonin. So really just a poor test. As a result, the IDSA, when they released their more recent community-acquired pneumonia guidelines, said procalcitonin is not recommended. So I'm really glad no one said it. You guys are ahead of the curve. And then let's see. So procalcitonin is out. Other next steps that we could use to identify pneumonia are really additional imaging. I think in the hospital setting, POCUS is available. CT chest is easier because you just put an order in the computer and wham, it gets done. You don't have to do anything yourself. We know that CT chest is going to be more sensitive than chest X-ray. This study examined outcome of doing early CT chest on patients in the emergency department suspected of having pneumonia. So they had 319 patients, all of them got a chest X-ray, and then they asked the attending physician in the ER to categorize pneumonia as proven, probable, possible, or excluded. They then CT scanned everybody and had them see, how that changed the diagnosis. 58% of patients were reclassified from those categories after the CT chest was done, and including some pretty striking findings. So a third of patients who didn't have an infiltrate on the chest X-ray did have one on CT. So we know it's much more sensitive. And then 30% of patients who had an infiltrate on their chest X-ray were found to not have an infiltrate on CT. And I think, we've all seen this. You do the CT scan and it turns out they have an effusion or just nothing sometimes. Just to say, the antibiotic management was changed in 25% of patients based on the CT chest findings. So we should just CT scan everyone. The problem with that is really twofold. Number one is the ionizing radiation of CT scan is much higher than chest X-ray. As you know, the unit that is used for this is millisieverts. And so a chest X-ray has 0.06 millisieverts and a chest CT has 8 millisieverts. So more than 100 times as much radiation. And, these units don't mean a whole lot to me. So to put it in perspective, the background radiation that your body absorbs in a year just from walking around is 3 millisieverts. So in a sense, one chest CT scan is going to give 2.5 years of radiation to somebody versus a negligible amount of radiation from the chest X-ray. The other issue is cost. The charge master price for a CT scan at University Hospital is $3,762 versus $800 for a chest X-ray. And with the billing, of course, nobody knows what anyone pays for that. So as Dr. Shi pointed out, the POCUS is really a great choice. I'm actually not that great with POCUS, but you can find consolidations, infiltrates with POCUS. And the cool thing for you guys who are in clinic, in the hospital, we order tests and don't think twice about it. But in the clinic setting, this is something that you can do right there with the patient and be able to change the management right in that moment. Studies looking at this, comparing it with chest X-ray, and I won't go into the details of this, but the sensitivity and specificity of a lung ultrasound are pretty superior to chest X-ray. So if done by an experienced operator, you can see these are the sensitivities and specificities much higher for lung ultrasound. And their gold standard was these are hospitalized patients. And so when they were discharged, they then looked at the diagnosis. And if the attending at discharge said it was community-acquired pneumonia, that was their gold standard. Did they do like a single view or a PA and lateral? They are, but you do a PA and lateral and you still, I'd have to look. I don't know what the modality of chest X-ray was on this, but it's a good question. I have the study, we can look. So what happened in case number 1 in reality was they did do a CT chest, which showed a consolidative opacity that's shown here, as you can see in this cut. And then procalcitonin was done and it was 0.46. So even if you wanted to use a cutoff of 0.5, you're like, yeah. So definitely not helpful. So now the question is, what antibiotics should we use? And again, we are going to review some basics today. So really just thinking about what organisms cause community-acquired pneumonia. There is a recent study kind of in the modern era looking at etiology of community-acquired pneumonia. The best one is this CDC EPIC study. If you ever do a study and you want it to be well known and repeated, you have to come up with a good mnemonic for it. So EPIC, I feel like, is pretty good. This was from 2 cities and they were able to enroll 2,259 patients. So it's a huge study. It's hospitalized patients with community-acquired pneumonia. And they did kind of a workup similar to what you might do for a community-acquired pneumonia patient. So blood cultures, respiratory cultures, so, you know, sputum culture, or if they were mechanically ventilated, they would do tracheal aspirate or bronchoalveolar lavage. They did a viral PCR panel, and then they did some serologies. Those are things that you would maybe do more in research than with in actual patient care. And then urine Streptococcus pneumoniae antigen. So this graph, I don't know that you can read it, but it shows what they found. The pie chart up here shows the different types of organism, and oh, there's my pointer. So the different types of organism, viral pathogens alone were detected in 22%, and then bacteria alone detected in 11%. And then the biggest slice of the pie with all this workup was 62% with no organism found. And so, you know, kind of disappointing. When you looked at the organisms that were found, the most common was human rhinovirus. So viral was definitely most common, followed by flu. Here we see Streptococcus pneumoniae. And so getting to bacterial pathogen enemy number one, strep pneumo. More viruses, and then Mycoplasma pneumoniae, so kind of the top cause of atypical pneumonia, and then some others here. So, you know, it's a little disappointing. We do this study and we end up with the majority of people have no diagnosis. So it's 2025. Can we do better than this? So, you know, I always thought we would have flying cars by now. Instead, we have these. So too bad. And if anyone has one of those, I'm sorry. Just so it turns out for infectious diseases diagnosis, we do have the equivalent of the flying car, the future that we were promised, and it's called next generation sequencing. Probably the more proper name for this is massively parallel sequencing. So this is metagenomic, meaning that it sequences all DNA or RNA present in the sample. So when you do something like a PCR or nucleic acid amplification test, you have targets of a known target. You see if there's a match, and that gets amplified. In this case, you're sequencing everything that's there, and then they use AI algorithms to subtract out any human sequences, and you're left with sequences of whatever organisms are present. This has been done for community pneumonia. This is a study out of China looking at severe community-acquired pneumonia. So all these patients were pretty much in the ICU, intubated, and they were able to get respiratory specimens. So a little bit different population from EPIC. You probably can't read the organisms, but what you can see is the blue and green bar graphs. So the blue represents organisms that were only found with next generation sequencing. And so just visually, you could see it's about double for most things. Green is organisms that were found with both conventional testing like culture and next generation sequencing. And then the red are things that were only found by their conventional testing. And the conventional testing is similar to what we saw in EPIC. So in addition to identifying a lot of these common pathogens about twice as often, there are a long list of organisms you can see here in blue that were only detected with next-gen sequencing. And so the interesting thing is that it kind of tells us in that 60% that we didn't see in EPIC, it probably was a lot of the same organisms that we already knew were going to be there. So Streptococcus pneumoniae, they found about twice as much of it with next-gen sequencing. And, you know, that would make sense. If you try to culture an organism, you probably gave some antibiotics in the ED, you killed the strep pneumo, and now you're trying to culture it. But if you go in there and sequence, you can still sequence the DNA from that dead organism. Just in answering our clinical question is what organisms do we need to look at? The bacteria that they found here, strep pneumo, Haemophilus influenzae, Staph aureus, Klebsiella, and Moraxella catarrhalis, E. coli. So kind of the list that we remember from med school and community-acquired pneumonia. Then atypicals, they have some chlamydia, legionella, and mycoplasma. One of the big downfalls of next generation sequencing is it does get everything. So if you do this, any organism that's there, whether it's significant or not, is going to show up. And so you can see in this slide, we've got Epstein-Barr virus. So if you get Epstein-Barr virus, is that really causing pneumonia? Probably not. Everybody in the room has Epstein-Barr virus. And then TTV, torquetinovirus, again, another virus we all have but have never heard of. It doesn't cause pneumonia. So these can be difficult to interpret. Going back to the question of antibiotics, for hospitalized patients, these are the recommended therapies. Again, these are probably familiar to you all from the wards. The top recommended regimen would be a beta-lactam, beta-lactam, ceftriaxone, taxime, and ceftaroline. So these are your third generation cephalosporins or Ampicillobactam. You're trying to get strep pneumo, and you're also trying to get some of those gram negatives. And then the macrolide, of course, that what we call atypical, these are really intracellular organisms. And so we're going to need something like azithromycin or clarithromycin. So that's your first choice. Second choice would be a respiratory fluoroquinolone alone. And respiratory fluoroquinolones are levofloxacin and moxifloxacin. And why is ciprofloxacin not a respiratory fluoroquinolone? It is because of strep pneumo coverage. So Streptococcus pneumoniae is not covered by Cipro. They all have great tissue penetration, including into the lungs. So if you have a different organism, Cipro is a great drug for pneumonia, but not for strep pneumo. And then third choice is going to be one of these same beta-lactams plus doxycycline. So again, combining typical with atypical coverage. For severe pneumonia, and this is really, you're thinking about mechanically ventilated and ICU patients. They don't recommend respiratory fluoroquinolone by itself, and really that's because of gram-negative resistance to fluoroquinolone. So if you're going to use a fluoroquinolone, combine it with one of the beta-lactams. Okay, so let's go ahead and move to case 2. We have a 47-year-old man with history of alcohol and tobacco use, hospitalized 2 weeks ago with a PE and discharged on dabigatran, now presenting with hemoptysis and chills. On exam, he has poor dentition, decreased breath sounds in the right base, and the white blood cell count is 13,000. So this is the CT chest. This is a cut from the CT chest, not a plain film, and it shows right lower lobe consolidative opacities and a moderate loculated pleural effusion. So first question, and this is going to be a big one for you to do medicine, is figuring out, we've got a patient with pneumonia. Do we send him home? Do we send him to the floor? Do we send him to the ICU? And how do we approach that? So this has been addressed. It's in the guidelines, and there's very good evidence behind it. So first question, really what it comes down to is, do you just go in there and you're like, yeah, you don't look so great, go to the hospital? Or do you actually use one of these tools? It's been shown that if you use one of the decision tools, more patients be sent home safely. So basically you'll send, instead of admitting a lot of people filling up UH, which it's already like bursting with patients, you'll be able to send more people home. And if you use the tool, the people you send home, they'll do fine. These are the two tools that are out there. The Pneumonia Severity Index, or PSI, is the best one and the one that's recommended. It has a lot of stuff on it, so you're just going to have to use an online calculator or like MedCalc. Curb 65, I think people like because you can remember it and use it, but it's just not as good at making the decision. So definitely use one of those tools. And then when we get to admission, it's also recommended to use criteria rather than just eyeballing the patient when you decide ICU versus floor. The IDSA guidelines have these major and minor criteria that you would use to decide on location. So the major criteria, this is common sense. If your patient has septic shock or mechanical ventilation, they're not going to the floor. So they're going straight to the ICU. On the other hand, the minor criteria are some lab values and findings, physical findings that you would use. And these are things that you would have to look at the list, right? They're not intuitive to say this is a really sick patient. But if they have 3 or more of these on the list, they should go to the ICU as well. And one of the most important things about this is studies have shown that if you send a patient to the floor with pneumonia and then they're upgraded to the ICU, the mortality is higher than if you send them straight to the ICU. So crashing on the floor and getting intubated at 3 a.m. is not as good as being in the ICU and having, that high level of care and being responded to more quickly. So for this patient, what antibiotics would you start? And really the crux of this is, would you cover MRSA and Pseudomonas? So you've got a guy who was just in the hospital. Is that a reason to add MRSA and Pseudomonas coverage? So HCAP, I'm going to kind of skip over this because it's like most people never heard of it and shouldn't. It's an obsolete diagnosis. So when is MRSA or Pseudomonas coverage needed? If your patients have hospital-acquired or ven-associated pneumonia, so anybody who gets pneumonia in the hospital, definitely put on MRSA and Pseudomonas coverage empirically. And the reason we focus on those two organisms is because they are multi-drug resistant, and our CAP regimens that we talked about are not going to have coverage for these. So we have to change the antibiotic that we choose to cover these organisms if we want to cover it. For community-acquired pneumonia, they say think about these two organisms separately, and then also think about the severity. So for mild to moderate disease, they would really say if your patient has had a positive culture, so that's a big thing. Look back through the cultures. If they had MRSA in their sputum within the past year, you should really cover them for MRSA. So I think that's kind of common sense. Things that happen again. If they have no risk factors, they don't need coverage. And then this one here is the one that's a little odd. They say if the patient was hospitalized in the last 90 days, got IV antibiotics, and locally validated risk factors for MRSA, then add MRSA coverage if they're in the ICU. So we don't have these. They don't exist. It's in the guidelines to do this, but there are no locally validated risk factors for MRSA. And so I think most people would say if patients in the ICU, we'd probably just add the coverage. Same thing with Pseudomonas, but just to say, you're going to look, if you see Pseudomonas in a past culture, you'll cover it empirically. The antibiotics that we're going to use are for MRSA coverage, vancomycin and linezolid. And of course, these are easy antibiotics to remember their spectrum. Vanc and linezolid, they cover all gram-positives for the most part, and no gram-negatives or anything else. So no gram-negatives, no anaerobes, no atypicals. Ceftaroline, you probably could use, the spectrum is there. It's like basically like ceftriaxone, but it adds MRSA coverage. The thing is, it hasn't been studied for pneumonia, and so it's not in the guidelines. And then daptomycin is another MRSA active antibiotic, but it does not achieve, it's activated by surfactant in the lungs, and so it's not effective for treatment of pneumonia. These are your Pseudomonas. So these are antibiotic topics that really are for all of your hospitalized patients. We think of what you're covering and whether these drug-resistant organisms are there. These are the antibiotics we would use to treat Pseudomonas. So the beta-lactams, Zosyn, cefepime, imipenem, and meropenem. Just to say, ertapenem that we use a lot for ESBL, it does not have Pseudomonas coverage. And then ciprofloxacin and levofloxacin, if you're trying to treat Pseudomonas with something oral, these are the only things that'll work. And so if it's resistant to these, you're out of luck. But these two do have Pseudomonas activity. And be sure to look at the antibiogram. Sometimes the patterns are surprising. So we kind of talked about if you don't have these validated risk factors, what do you do? And again, this is for ICU patients with recent hospitalization. You have to just come up with your own thing. There's no correct answer there. And just to say, when you do start these broad spectrum antibiotics, MRSA and Pseudomonas coverage, have a plan to narrow it. And the big thing is make sure you get some cultures that you can use that information to then narrow the antibiotics if you don't see MRSA or Pseudomonas. So blood cultures are, occasionally positive, usually not in pneumonia. Respiratory culture is huge. So we generally say in community-acquired pneumonia, don't bother with sputum cultures. It's just basically like a spit culture. It doesn't help. But if you're going to start these broad spectrum antibiotics, definitely get it. It'll help you figure out if you can narrow. And then what about MRSA nares? We'll talk about that in a minute here. And then 48 hours in, you don't see these, you can narrow. And that modality is used for all other infections in the hospital. So you start broad, you get cultures, and then 48 hours in, you look and see what you found. If you haven't found these drug-resistant bugs, you can narrow in. So MRSA nares, MRSA colonization in the nose often precedes invasive infection. And so this was looked at to see whether you can predict whether pneumonia would be caused by MRSA. This is a huge study from the VA that looked not just at community-acquired pneumonia, but basically every single respiratory specimen. And at that, the VA has universal screening. So everybody that sets foot in a VA and gets admitted gets MRSA screening. And what they found is a negative predictive value of 96%. So if your MRSA nares is negative, that means there's only a 4% chance of having MRSA in your respiratory culture. And the positive predictive value wasn't great, so 35%. So if you had a positive MRSA nares, there was only a 35% chance of finding MRSA in your respiratory culture. So with a high sensitivity and a high negative predictive value, this is a good rule out test. So if you start MRSA coverage for pneumonia, you do a MRSA nares. If that MRSA nares is negative, they don't have MRSA pneumonia, you can stop your vancomycin or linezolid. And then, just to say, editorial about MRSA nares, never use MRSA nares to ask about MRSA when you can actually interrogate the site you're interested in. So a patient has a wound with like pus coming out of it, and you're like, I wonder if there's MRSA in there. Don't culture the nose, right? Culture the pus that's coming out. And we occasionally see people do crazy stuff in the hospital with that MRSA nares. Okay, so moving to case number 3, this is a quick one. We've got a 48-year-old man with a 15-day history of malaise, cough, hemoptysis, and pleuritic chest pain. Fever of 101.8. He has dental caries and periodontal disease. White blood cell count is 20,000, and the chest X-ray shows, you can see, where's my arrow is not. Oh, my arrow doesn't show up on here.
You have to move it off the screen this way. It's acting as a second screen.
Okay, well, anyway, in the kind of in the right mid-lung field, you can see an air fluid level. The X-ray is not real good quality, but you can see that air fluid level. So there's a cavity there with an air fluid level in it. And there's another one where the arrow is pointing, but that one's completely imaginary. So the purpose of this case is to say, when should anaerobic coverage be added? It's really for lung abscess and empyema. It's not needed in pneumonia, including aspiration pneumonia. So this is in the guidelines. They don't recommend coverage for anaerobes in aspiration pneumonia. Again, just lung abscess and empyema. There are some studies that look at effects of anaerobic coverage, and it's probably potentially harmful to the patient. It does kill a lot of the normal flora. A lot of our normal gut flora is anaerobic. And there are associations, these are not, these are observational studies, but associations with increased mortality and increased rates of vent-associated pneumonia. These are ICU patients who are given anaerobic coverage. Okay, so this is both inpatient and outpatient. We've got a community-acquired pneumonia patient. How long do we treat? Very good evidence to show that shorter courses of antibiotics are fine for this. So a minimum of 5 days, and then you want to see that the patient has improved, and that's defined by improvement in vital signs, patients tolerating PO, and mental status is back to baseline. Multiple randomized controlled trials support this, and they typically would look at short, which is 3 to 7 days, versus long, which is more than 7 days. Just to say, if it's day 5 and your pneumonia patient is still not improving, something is wrong. So look for other problems. Do they have an abscess? Do they have an alternate diagnosis? They should be, they should be a lot better by day 5. For hospital-acquired and vent-associated pneumonia, 7 days is the recommended duration. And again, multiple randomized controlled trials comparing short course, which is 7 to 8, versus long course, which is 10 to 15, and seeing no change in outcomes. Okay. So here's a question, is steroids, should we give steroids for patients with community-acquired pneumonia? And if so, who? Our guidelines, the IDSA guidelines, were published in 2019 and just said no steroids. European guidelines that were published more recently said give for patients with shock. But there has been There is one randomized controlled trial published since then that probably answers this question. Again, you have to have a good mnemonic. This is the Cape Cod study. So 795 patients with severe community-acquired pneumonia. So all of these are ICU patients. They excluded you if you had influenza. This was pre-COVID-19, so they didn't have any of that. And then septic shock can be its own indication for steroids, so they did not include those patients. And then if you were DNR. But this was the finding. I don't know if this is visible, but this is mortality by day 28, and the mortality in the patients that were given steroids was 6% versus just about 12% in the placebo. So your mortality was cut in half. And this was statistically significant with a p-value of 0.006. So in summary, if you have severe community-acquired pneumonia, basically your ICU patients, they really should get steroids. Okay, so I think this might be our last case. This is a 73-year-old man who was diagnosed with gastric cancer 4 months ago and started on chemotherapy and immunotherapy, now presenting with productive cough and dyspnea. Admitted to the ICU, and this is the CT chest showing right grid and left consolidative opacities. So patient was put on Zosyn and micafungin. This is from the literature, you know, we didn't choose these antibiotics. And then by day 5, the patient was not getting better and had worsening hypoxia. So any guesses as to what this might be? A little bit of an unusual case here. Pneumocystis, great. So somebody said PCP. So PCP is probably the first thing that I would think of. You've got somebody who's immunocompromised, and they're presenting with pneumonia. We gave something that should help bacterial, but you know, micafungin will not treat PCP even though it's a fungus. And so PCP is probably the first thing you want to think of. This turned out to be just something to be aware of: pneumonitis due to immune checkpoint inhibitors. So these are your like nivolumab, pembrolizumab. Just to be aware that one of the side effects is these cause pneumonia, and it can look clinically a lot like community-acquired pneumonia. More and more patients are on these for a variety of malignancies. So signs and symptoms can be shortness of breath, productive cough, hypoxia, fever. Some of the clues is that they'll often have colitis and mucositis or rash. And so about half of the patients with lung involvement will have those in addition. That can be a good clue. So I think, you know, realistically, what we end up doing with these is you can't really tell if it's bacterial pneumonia or not. And so they get treated with bacterial pneumonia, and then glucocorticoids are helpful for treatment of the checkpoint inhibitor pneumonitis itself. Okay, so those are the cases. I wanted to move on to some of the newer things out there. And I've been in practice long enough that new for me is like 10 years now. When I was in residency, new meant like 6 months. So omadacycline is an antibiotic that can be used for pneumonia. This is like, it's a tetracycline derivative. So it's kind of like doxycycline or minocycline, but much broader spectrum. It's both IV and PO, and it kills typicals, atypicals, including MRSA. Its only really big hole is Pseudomonas. It does have randomized controlled trials for community-acquired pneumonia and shown to be non-inferior to moxifloxacin. So it's an option for treatment of community-acquired pneumonia. I think it's interesting to have this, but you know, moxifloxacin is generic and readily available. And this omadacycline, if you want to spend your afternoon on the phone with the insurance company, you know, that's where you're headed. It's going to be really expensive. So it's good that there's an option out there. It's probably not ready for prime time. Lefamulin is another new that is a novel antibiotic class. It's both IV and PO, and it has good coverage for usual community-acquired pneumonia pathogens. It doesn't have great gram-negative coverage, but so like the previous one, there are randomized controlled trials showing that it's effective for treatment of community-acquired pneumonia. It's been compared to moxifloxacin. Again, your issue would be, you know, wait a few years until it's generic probably. I think this one was brought to market with community-acquired pneumonia studies, but it's being repurposed for other things like difficult to treat STIs. So those are what's out there for new antibiotics. In the hospital setting, what we deal with is these superbugs. So the pirate bacteria, the microbiologists have this joke that you get the susceptibility pattern and it's all R. So it's like a pirate. These are the antibiotics you use for those. And it's not so much important for y'all to know these because I think if you're using these, you're probably getting an ID consult. But these are the broad spectrum gram negatives. The things to know is that the names of them would suggest that they have broad spectrum coverage. So, you know, if you put somebody on Zosyn, you're getting great gram positive coverage, you're getting anaerobe coverage, along with all this gram negative coverage. These new ones like ceftazidime, avibactam, ceftolozane, tazobactam, and cefiderocol, they really only have gram negative coverage. So don't rely on them for gram positives or anaerobes. This one, sulbactam with durlobactam, only for Acinetobacter. So it's like very specific. There are these carbapenem combinations, and these are, of course, the coverage is expanded. So you can count on, you know, anything that meropenem coverage, obviously this Vabamere that has meropenem in it is going to work. So they are good for gram positives and anaerobes in that case. But yeah, just to say, if you're using one of these, remember you've got to pair it with something for gram positives if you're treating pneumonia. This is back to our slide from the EPIC study where we talked about causes of pneumonia. And the ones that I've circled are vaccine preventable illnesses. So we can take a minute to talk about vaccines and the prevention of pneumonia. So the circles are around flu, Streptococcus pneumoniae, RSV, and coronavirus. This slide is really cool. So this is rates of invasive pneumococcal disease among adults 65 and older over time. And the red line is, you know, the first pneumococcal vaccine had 7 serotypes in it. And starting in 2000, we started vaccinating children. And by vaccinating children, the levels of disease in adults fell precipitously, which is cool because they're not actually getting vaccinated. So these pneumococcal conjugate vaccines are great for herd immunity. And the reason is they stop invasive disease, but they also stop colonization. So if you give a kid PCV7, they will not get colonized with those 7 serotypes of Streptococcus pneumoniae. And of course, colonization is what happens to most people. So if you've thought about it, your community-acquired pneumonia patient, strep pneumo is the most common, but we don't put them in isolation, right? We don't wear a mask for them. We let them cough strep pneumo all over us when we're in the room. The reason is we tend to get colonized, and then the attack rate is actually really low. But again, with vaccination, you can stop the colonization. Of course, that prevents subsequent infection. These are the 7 strains that were in the first vaccine. And so then what happened is some of these other strains started to become more prevalent. So this is the strain replacement theory, which is you open up a niche that's empty. Those 7 strains are gone. So the other strains to take their place. And you could see that happen. So then around 2010, we developed the PCV13. This blue then shows that those additional 6 strains that were in the PCV13 start to go down. So this is all ancient history. Here's where we're at today. These are the recommended pneumococcal vaccines. So your choices are this PCV15 followed by Pneumovax, which is a different type of pneumococcal vaccine with 23 strains. PCV20 is an option. And then the newest one is this PCV21 or Capvaxive. And it kind of looks like, you know, you've got one with 20 strains, so one more strain is slightly better, right? But what they did with this is they looked at, this is for adults, they looked at strains that weren't really that useful for adults, like adults were not getting infected with them. So they took a bunch of those out and replaced them with strains that are more common in adults. And so the strain coverage from the PCV20 that's out there now, the Prevnar, is up to 58% versus 85% with this newer PCV21. This is FDA approved, but not yet widely available. So do y'all have this? No. Are you using PCV20? So I think from a, from a market share standpoint, we're all seeing outpatients. The desirability of having to figure out whether they've gotten their PCV 15, and then how long do I wait? And then I give the PPSV 23, and then, oh, and then what do I do if they got the PPSV 23, but they didn't get the PCV 15? It's just like, you know what? We're just going to give the Prevnar 20. So RSV vaccines are relatively new. There are 3 choices out there. So the indications for these, again, RSV does cause pneumonia. It's particularly problematic for really young kids, which I didn't include this in the talk, but there are also there's also passive immunization for RSV prevention. For adults, age 75 and older, we recommend that they get the RSV vaccine, and then 60 to 74 with comorbidities, pretty much any chronic illness. These are FDA approved for 50 and older, but when the evidence was reviewed, the ACIP felt like age 50 to 60 was not that high risk. And at least one of these has been associated with Guillain-Barré. And then COVID-19 vaccination. So 24, 25, this is probably stuff you guys are well familiar with by this point. This is people at the beginning of the pandemic, everyone was asking, like, is this going to be like the flu shot? And of course, we had to wait and see. Well, in 24 was kind of the first year where it's like, yeah, this is like the flu shot. And so the ways that it's similar is that the vaccine is likely to be updated every year with a yearly formulation that more closely matches the strains that are circulating. And then FDA approval is based on showing efficacy to the prior strain. So like the flu vaccine, you don't have to go through that whole process every single year. There are 3 choices. There's the 2 mRNA vaccines, Pfizer and Moderna, and then Novavax, which is a non-mRNA. Any of those are great choices for COVID vaccination, and it's recommended for every adult once a year. Flu vaccine, there are a huge number of choices. New for 24 and 25 is that we've gone to a 3-valent. There, previous years, there were 2 strains of A and 2 strains of B. One of those strains of B is no longer circulating, and so now they're all 3, so 2 strains of A and 1 strain of B. For most patients, they're interchangeable. If you have patients that are 65 and older, there are specific formulations that are preferred. It's going to be the high dose or the adjuvant. And then for immunocompromised, there is FluMist, which is live influenza, so avoid that in immunocompromised patients. And then if your patient has vaccine allergies, the CDC has a very good page of which, how to determine if they have an egg allergy. There's certain vaccines that are not made using cell culture in eggs, and so you can use those. So that is it. These are my kind of main take-home points. Corticosteroids do improve mortality in patients with severe community-acquired pneumonia. Bedside ultrasound is superior to chest X-ray for diagnosing pneumonia. Procalcitonin doesn't reliably identify bacterial pneumonia. It's probably not a good test for anything. Don't order it. And then RSV vaccination is relatively new. It's for everyone over 75 and anyone 60 to 74 with comorbidities. Last thing I probably didn't put on the slide is MRSA nares is a great test to rule out MRSA pneumonia if you can't get a respiratory culture. So I'll stop there. We do have a few minutes, and I'm happy to take any questions that you all have. So yes. Yeah, that's a great question. So another thing that people have looked at procalcitonin is monitoring response to treatment. So can you order procalcitonin, and then if you see a certain response, you can stop it? I would say pretty much considering the recommended course of antibiotics is 5 days for community-acquired pneumonia, and it's going to take you a day or 2 to get the procalcitonin back. It's probably not going to be helpful. You can probably just, if you're ordering it, just look at the patient. If they look fine and it's day 5, just stop the antibiotics. So yes. Yeah, that's a good question. I would probably do it based on imaging, if there's imaging that suggests necrotizing pneumonia, if the patient's coughing up blood, this is not a guideline or an official recommendation, but if they have regular old infiltrates on their chest x-ray, I probably wouldn't. But yeah, again, if it looked like cavitary disease, then yeah. Mhm. Yes.
We treated, and by the day five, that getting better. If you already had a chest X-ray that have no big finding on the thing, they, what would you do? Do you repeat the
Yeah.
chest?
So the question is, if patients not getting better. So first of all, the imaging findings of pneumonia will not get better. So even a patient who is like totally better, discharged from the hospital, and you see them a week or two later, if you x-ray them, it may look the same as when they were hospitalized, whereas the patient may have shown improvement. So this, when we're saying if they improved at day 5, we're talking about these parameters. Are they still fevering? Are they still hypoxic? Are they still confused? If those are all better, really, you just shouldn't do an x-ray. If the patient, you would do an x-ray because you suspect that maybe they have an effusion or some other complication like that. But yeah, just to say, if you had an outpatient who was clinically not improving at day 5, that would be, then you would want to think about getting an x-ray again to look for, do they have an empyema? Do they have a lung abscess? Is this something else, right? Is something else going on? So, yes.
Scoring guidelines, like member of a nursing home or something like that.
Mhm.
Like part of that risk factor, or is that completely different?
Yeah, that's a good question. And I think, it's not on the PSI, but a homeless person, I mean, these guidelines, as much as I said, yes, you should, don't just eyeball somebody, use the decision tree. A homeless person has a distinct disadvantage in terms of follow-up and in terms of access to care, in terms of like, you're sending somebody home, you hope there's a family member there that can keep an eye on them. I would see that as an indication to sort of abandon the PSI and lean towards admission, because I mean, you don't want to send somebody to the street who's sick. I think that's appropriate. Yeah, I mean, again, all these things, they end up being even, the guidelines, they're guidelines, right? So if it's saying this patient can go home, but home is the street and they don't, you're worried about them, I think you should just admit them. So.
Get the labs and high staff and patients having to wait there, but then talk with them on,
Yeah,
or not, and the labs part of that.
Yeah, that's true. That's a big disadvantage of the PSI is there are lab values, and even some of them, I think that may have like O2, like partial pressure of O2, which is like nobody does an ABG anymore. So those need to be updated, and I'd probably just I'd probably just ignore the partial pressure of oxygen and do oxygen saturation. But yeah, the question of, so would you, not having those values, would you get the labs and then potentially call them if they don't look good? I think that would be a good approach if there's somebody who has, they're reliable, you think they'll answer the phone and that kind of thing. Yeah. Yeah. So I think it must, I mean, thinking about how it was developed, it does have a lot of lab values on it. And so I think it's more of an ED type setting, because if you're in a clinic, you won't be able to use lab values. And I can rewind to it, but there's at least, yeah, so they're not all on here. But there's going to be lab values on it. So appropriate for an ED. If you're seeing somebody that doesn't look great in clinic, you can either send to labs or send them to an ED. Yeah. Yeah, my pleasure.